but it's just a little bit more cautious. It's a little bit more sort of controlled, and we're not sort of going to go home. Alright guys, welcome back. Case of the week. It's been a hot minute since we've done one of these before. A few bits and bobs of sort of admin to kind of catch up on. Yes, rocking some kind of sort of lockdown beard at the moment. I'm also rocking some kind of lockdown haircut at the moment. It is terror, hence the cap is staying on. Additionally, obviously, we are still open. We're still open to sort of see injuries sort of face to face. There are a few sort of hurdles you need to kind of clear before you kind of come in and sort of see us. Obviously, we're not doing any kind of routine work. It's just pain and disability that we're sort of looking at. Obviously, if you are kind of concerned or need to kind of come and see us and aren't sure whether you kind of cross those sort of hurdles to kind of come and see us, just drop us an email, something like that. We'll kind of figure it out. Okay, case of the week this week. It's actually sort of super interesting, and I wanted to use it to kind of highlight the importance of why we are still pushing virtual appointments and the benefits that can be found through them. I think virtual appointments are always really difficult, right? Because it's not the same as coming in and sort of seeing us, and we kind of definitely kind of get that. But it's not it's not that they aren't of benefit, right? So this is a patient that I sort of saw virtually. I've only seen once virtually. They came to me with a sort of slight kind of hip issue, nothing sort of too crazy. That ordinary in clinic, we would probably kind of see, and we sort of move the hip around a bit, and we'd sort of poke and prod a few things, and probably do a little bit sort of soft tissue work, and that would be all cool. And we kind of obviously sort of give some exercises to kind of go away with. Obviously, virtually, we're not able to kind of do that. So the pathway for that was, again, we'd sort of assess, we'd sort of diagnose. A lot of that assessment took place in terms of functional movement. So, can we squat? Can we extend the hip? Can we, single leg squat? Can we, jump, land? And also sort of clinical history. So, what causes it to be painful? What are you doing most of the time during the day? Are you sitting down most of the time during the day? Are you standing up most of the time during the day? And kind of actually understanding the sort of greater context with that. Now, that's obviously what we would do in clinic as well, right? So yes, we get the sort of physical, how does this hip joint move? How does it kind of feel? Is this structure tight? Et cetera, et cetera. But we also do move. Do this movement, do that movement. What does that tell us? The history of, right, what exercise do you do? What do you do most of the time during the day? Do you sit down most of the time during the day? Are you very mobile, et cetera, et cetera. So we kind of went through that as a sort of process, to kind of, figure out a sort of rough diagnosis. And it's not quite as accurate as we would see in here, but it's a very kind of, it's a fairly kind of accurate sort of view on what we're sort of seeing. Ideally, yes, we'd like to sort of see it in here, but again, sometimes we can't, right? So yeah, we sort of set some exercises based on that. Basic hip exercises, so some anterior hip mobility, and some sort of posterior hip sort of stability, strength work, bit of recruitment work, that kind of thing. Nothing too complex. One of the things about that virtual appointments, because we're not seeing people face to face, we are being a little bit more conservative in terms of our sort of exercise rehab regime. Normally, when we're sort of seeing patients face to face, we know what we're sort of seeing, so we can be a little bit more aggressive with that. So we can progress a little bit quicker. We can go and chase, gains, whether that be mobility gains, strength gains. Virtually, it's really important to say that we are a little bit more cautious. Now, that doesn't mean that being cautious is inaccurate or non-related to structure or unrelated to sort of injury. But it's just a little bit more cautious. It's a little bit more sort of controlled, and we're not sort of going quite so gung-ho. It's a minimal or more minimal intervention and looking at right, what effect does that have? Positive effect, cool, awesome, gravy, let's progress it on. Negative effect, well, that margin for error is quite small, so therefore we can bring it back again. So yeah, we sort of set some exercises, and we kind of said, well, go and do, spend some time with those exercises. They're not overly kind of complex. We could look to progress them on. Again, that would be, the sort of second phase of what we would do. We may well in clinic have sort of said, actually, you know what, like you can probably sort of do these, so let's progress you onto those. But that would be the only real sort of difference between what we did in clinic and what we've sort of done with her over virtual. She actually then sort of came back to me and said that she's been doing her exercises 3 times a day, which is good adherence. I like that. Have had a massive improvement. Sharp pain went within sort of 2 days, and tightness within after about sort of 4 days. Back running and all is fine. So what you can kind of see is actually quite a lot of sort of injuries. Actually, we can sort of deal with that, and that's the bulk of actually what we should be doing. Is actually, doing exercise prescription, not necessarily all just hands-on. There are some things that ideally, yes, we'd like to see in clinic because they're a little bit more complex and require us to actually sort of really delve down on specifics with structure. But, quite a lot of the time, actually, we can sort of see that virtually. It's a lot, as I say, based around, sort of functional tasks, simple functional tasks, and then sort of, a few sort of simple tests that we can do based on then sort of history, that sort of subjective history that we always sort of take, and that then sort of giving us a good idea of, well, these exercises would seem to fit. And then from there, as I say, it's then just to kind of catch back up again. So we catch back up after week, 2 weeks, 3 weeks, whatever that sort of interval is, and we can see what effect has that had, how do we then sort of progress it on, how do we then give guidance in terms of sort of progressing it sort of forwards, and then obviously that becomes the next sort of set sort of intervention. I think, as I say, in particular at the moment, virtual appointments are really important sort of component to what we do. They're not the be all and end all, as I say. We can still see patients face to face, but the more in which we can sort of decrease exposure, the more in which we can see patients virtually, the better. And as I say, if we can, effectively get the sort of same outcomes because we are, actually putting in place effectively the same intervention just with no sort of hands-on, then that suits really, really well for both of us during sort of this time. But that's us for now. Obviously, if you've got any questions about virtual appointments or any questions about whether you'd be able to kind of come and see us face-to-face in clinic, again, drop us an email, drop us a message. All the details are sort of all over the place, all over our sort of social media. And again, we can then sort of figure out from there what the sort of best outcome for you is. But don't forget to like, follow, comment, subscribe, etc., etc. Stay safe, and we'll catch up soon.